Okay, so I've got no relevant disclosures. I am a consultant for several pharmaceutical companies, but they do not have any impact on this talk today. The outline of my talk briefly, I'm just listening to that wonderful talk by the previous speaker. I'm going to outline basic uterine malignancies. For the purpose of this talk, I'm going to focus on endometrial cancer. Obviously, there are a lot of other uterine malignancies that we're much more reluctant and reticent to treat from a reproductive medicine standpoint. So we're going to focus primarily on endometrial cancer today. I will discuss briefly the fertility preservation options, which, as you all know, comprise oocyte cryopreservation, embryo cryopreservation, and ovarian tissue cryopreservation. And again, just because of the time constraints and the title of the topic that I was given, I will be focusing more on protocols surrounding oocyte cryopreservation, embryo cryopreservation, rather than ovarian tissue cryopreservation in this particular talk. So we all know that endometrial cancer is most often diagnosed in the postmenopausal years. However, there are a significant number of patients in reproductive age who can be diagnosed with endometrial cancer. And about 17% of women in the 45 to 54-year-old age group can be, so 70% of all endometrial cancers are in the age group of 45 to 54. And then the ones that we mostly focus on and think about when we're talking about fertility preservation are really those 44 years or younger. And that is, those patients comprise up to 9% of all endometrial cancer cases. There are some occasions where we'll treat patients over the age of 44, but really the outcomes are very, very poor in terms of either oocyte cryopreservation, embryo creation, or ovarian tissue freezing in patients over the age of 44. So we really use that as our cutoff here at Harvard. The endometrial cancer subtypes, again, two broad categories that you all know about, endometrioid and type 2, which are the more aggressive clear cell serous endometrial carcinomas, mixed tumors. But again, for the purpose of this talk, I'm going to be focusing mainly on low-grade endometrioid, garden variety endometrial malignancies. So some key considerations when these patients present to us are, can the ovaries be preserved? If so, when can we stimulate these ovaries? If we can't preserve these ovaries, can we do a histopathological assessment at the time of hysterectomy, followed by ovarian tissue cryopreservation? So that is an option that we offer patients here. If there's no extrauterine disease evident, we can consider histopathological assessment at the same time as hysterectomy, and then we will freeze cortical strips. If, based on our previous speaker's talk, if there's a low-grade malignancy, can the uterus be preserved? What are the genetic components of the malignancy? We briefly mentioned Lynch syndrome, which is obviously one of the more common genetic syndromes associated with endometrial cancer in young women. And then what steps can we take during stimulation to mitigate exposure of the endometrium to estrogen and the theoretical risk for disease progression? This is probably the most important slide in the entire talk. It's common sense, but every single patient that presents to us with an endometrial cancer, an endometrial hyperplasia, or any cancer at all requires a full multidisciplinary approach to their care. We have multiple specialists involved in their care throughout, and they include gynecologic oncology, and we're fortunate that I think most of the gynecologic oncologists are still have gone through OBGYN training, and so reproductive medicine is still in the backs of their minds somewhere, more so than our medical oncology colleagues who don't always bring it up with the patient, and the same thing applies to radiation oncology. But it's really important to include all of these subspecialists. We often include maternal fetal medicine to counsel the patient up front about potential effects of a pregnancy, to help them make an informed decision up front. Would they want to carry a pregnancy in the future? What are the risks associated with that? Our pathologists obviously go through our specimens in great detail. Cancer genetics, I briefly mentioned Lynch syndrome, but we test for a variety of different genetic conditions that may change that patient's risk, and also because the risk has changed, that may change our counseling. Reproductive endocrinology is obviously where I come in. And then again, super important for our patients is the psychological aspect, the counseling that goes into it. This is a very stressful time for patients in general. We want to make sure that they're fully aware, fully informed, and have all the information available to make the best possible decision for them. And just to reiterate the last speaker, individualized care is crucial in the management of these patients. We can't take the same approach to everybody because not everybody has the same life goals. Some of these were already discussed. Some of the fertility sparing options that we talked through with our gynecologic oncology colleagues include hysteroscopic resection. We don't tend to do that a huge amount unless there's an obvious localized lesion. Progestin therapy, which was already mentioned, oral, a levonorgestrel IUD, or a combination of both. And we most commonly use a combination approach with an IUD plus oral progesterone acetate. The majority of well-selected patients will respond, and I emphasize the well-selected part, and that's why the multidisciplinary approach is so important. We typically will rebiopsy 8 to 12 weeks out. Most of them, if they will respond in this window between 8 weeks and 12 months. And we typically perform endometrial sampling every 3 months. We know that even if we get clearance and there is no longer any obvious cancer cells, or if there's hyperplasia, that there's a recurrence risk of 25 up to 41% of the endometrial cancer recurring. And so the mean time to recurrence is somewhere between 1 to 2 years for most patients. And so what this does is it presents this golden window of opportunity in order for us to try to help these patients preserve fertility, one, and two, potentially carry children themselves to become parents. So when we talk about mitigating risk in endometrial cancers, we have several different options. One, and this is particularly pertaining to ovarian stimulation, assuming that our plan is to try to preserve either oocytes or embryos, or a combination of both. And so one thing we can do is that we can delay stimulation until a negative endometrial biopsy. And again, we don't always do this, particularly in hyperplasia patients and very low-grade endometrioid cancers. We feel relatively comfortable proceeding with stimulation without a negative biopsy. But again, this is all individualized care. We discuss the case with the patient. We discuss the case with all of the multidisciplinary physicians and ancillary staff that I mentioned before to decide when we're going to start our stimulation. And again, the conversation is very different for a 29-year-old who's obese versus a 41-year-old. And so some patients we've got more time to play around with, and some patients we recommend proceeding with stimulation in a more urgent fashion. We can stimulate with the IUD in place, and I'll talk through that a little bit. We used to think that having a Mirena or having a levonorgestrel IUD would affect the stimulation. That does not appear to be the case, and we have extensive experience here with stimulation with the IUD in place. I'll talk about protocol types, the types of stimulation we use and why we do that. And then the other part is the addition of an aromatase inhibitor, and I'll briefly talk through the data that exists for that. So this is from a Fertility and Sterility article. A group of colleagues in UCSF in San Francisco published this. We have our own internal data to support this, very similar outcomes. But briefly, when they looked at patients stimulating with an IUD versus without an IUD, these are primarily elective oocyte cryopreservation patients. So those are the patients that we see most of the time with an IUD in place. They're not actively trying to get pregnant, but they do want to preserve their fertility. They're not cancer patients. But when we look at the outcomes between the group with an IUD in place and without an IUD in place, the peak estradiol is slightly lower when there is an IUD in place here. The number of the days of stimulation, there was a slight increase with an IUD in place, less than a day. But when we move to outcomes, again, look at the number of oocytes, which is ultimately where we define success, is our treatment outcomes. No statistically significant difference between the two groups. Whether you have an IUD in place or you don't have an IUD in place, outcomes are very similar. And so that is why both in elective oocyte patients, but in particularly for this talk, patients with either endometrial hyperplasia or low-grade endometrial cancer with an IUD in place, we tend to leave the IUD in place. And we always recommend, again, that's one of the reasons, again, why we recommend a dual approach with both oral progesterone and localized progesterone effect on the endometrium, because when we're doing stimulation, we can leave that IUD in place and just stimulate through it. When we talk about stimulation protocols and IVF, two broad categories. One is a GnRH agonist protocol, the other is a GnRH antagonist protocol. I tend to like the GnRH antagonist protocol, and I use a GnRH agonist trigger, and I'll explain why we do that. It enables the IVF sequence to be reduced to less than 2 weeks. So patients are actively taking drugs for less than 2 weeks with an antagonist protocol. There have been multiple studies showing that there's a lower gonadotropin consumption with an antagonist protocol. It allows for that trigger flexibility. Again, if we do an agonist protocol, a long lupron agonist, then we're kind of stuck with an HCG trigger. So using an antagonist protocol tends to shorten the duration, tends to shorten or decrease the gonadotropin consumption, and that allows us to use either a lupron trigger or GnRH agonist trigger, an HCG trigger, or a combination or a dual trigger. And there's been multiple studies showing similar outcomes between the antagonist and the agonist protocols. So it's not to say that the agonist protocol is wrong. You certainly could do that in endometrial cancer, and we certainly have done that with endometrial cancer cases here. But our first line is an antagonist protocol for the reasons I just outlined. Our typical antagonist protocol, we start gonadotropins day 2-3 of menses in the early follicular phase. If a patient has an IUD in place and they're not menstruating, we'll just bring them in for blood work and ultrasound to measure an LHP4 estradiol and do an ultrasound to see where they're at in their cycle. As you know, about 30% of patients with an IUD in place will be anovulatory, and that can be even higher when it's first put in. And so we'll do an ultrasound, do some blood work, see where they are in their cycle, and then just start them if they are in the early follicular phase or they're suppressed. We most often use a mixed protocol with both recombinant FSH and some kind of LH, whether that's urinary derived HMG or whether that's a low dose HCG addition to mimic LH. We typically give gonadotropins for 4 days before monitoring. Our goal, same as everywhere else, is to increase follicular size by 1.5 to 2 millimeters a day. We expect the estradiol to increase 30% per day typically. I'll talk about the addition of an aromatase inhibitor in a second. And then we typically start the antagonist when the estradiol is above 500. That again, with an aromatase inhibitor in place, we ignore the estradiol largely, and we just go based on follicular size. We wait until the follicle is about 14 millimeters, and we typically tell the patients to take the antagonist at the same time every evening for consistency. Antagonist dosing, I'm sure you have similar antagonists. We use acetaldehyde or GnRH, and as you all know, causes immediate suppression of endogenous hormones and prevents our LH surge and prevents premature ovulation. As we know, when follicles are about 18 millimeters, they have a 65 to 70% chance of a mature oocyte, and this percentage decreases with smaller follicles. And so the goal, as with every IVF cycle, is to try to maximize the number of follicles in that 16 to 22 millimeter range. So we will forego some of the larger follicles in order to increase the number of follicles in that target range. So during the antagonist cycle, and I think this is particularly important in endometrial cancer and endometrial hyperplasia, is using a GnRH agonist trigger, and we typically use 8 units of leuprolide acetate. The advantages of an antagonist, of an agonist trigger rather, it's a more physiologic trigger. Again, you're getting endogenous surging of LH. And following the retrieval, there's marked pituitary downregulation and luteolysis, which I think is helpful in mitigating exposure to the hormonal surge that typically happens during IVF. And as we know, this is less of an issue for this particular talk. With a leuprolide acetate, it's extremely rare to get ovarian hyperstimulation syndrome. Some of the disadvantages of a leuperon trigger or a leuprolide acetate trigger are trigger failure, which occurs about 2% of the time. This is a great paper by the group at Cornell in New York looking at predictors of treatment failure with an agonist trigger. And we see this clinically all the time. Might not be as common in your population, but the patients that fail a pure agonist trigger are typically the younger, skinnier patients who are hypothalamic. And so those patients typically don't get the endogenous surge that we expect to see following an agonist trigger. And so we're quite selective in that regard. Most of our patients that we're talking about for the purpose of this talk, the endometrial hyperplasia and endometrial cancer patients, most of those patients are going to be obese. Some of those patients will be PCO patients, and so those patients are far less likely to fail an agonist trigger compared to our hypothalamic patients. How do we mitigate risk for trigger failure? Well, we sometimes measure an LH and a P4, luteinizing hormone and a progesterone, the day after trigger to ensure that they have had an endogenous surge and reaction. We expect the LH to be above 15 millionunits per milliliter and the P4 to be above 3 nanograms per mil. We don't always measure that, but especially when there's a cancer patient, we don't want to miss it. And so even if the patient's at low risk for agonist failure based on their body habitus and their other patient characteristics, we'll still measure the LH and P4 in those patients because we're trying to be as efficient and effective as possible, and we don't want to go to an egg retrieval and find that the trigger has not worked. And so for most of these patients, as I said, it won't be an issue because most of them will respond because they are mostly obese and those are not the patients at risk for failure. But if there happens to be the outlier that we're worried about treatment failure, we would give a dual trigger up front rather than a pure HCG trigger. Again, we try to decrease the dose of HCG because that will decrease the exposure of the endometrium to estradiol after egg retrieval. So we want to give the lowest dose of HCG that will be effective. Most of the time I don't use any HCG at all. Most of the time I'll use a pure agonist. But if we are going to use an HCG, I'll use quite a low dose, about 1500 units of HCG. If we give a pure agonist and we get unlucky and we happen to find the day after the trigger that the LH and the P4 are low or one's high and one's low, then we'll often re-trigger with low dose HCG, sometimes 3,000 units or 3,500 units, and bring them back 36 hours later for an egg retrieval. So we always, in these patients with endometrial hyperplasia or endometrial cancer that I'm stimulating, I will always add an aromatase inhibitor. I use letrozole, and it's, as most of you know, a highly selective third generation aromatase inhibitor. The estradiol is suppressed by up to 90%, and the usual dose we use is 5 milligrams. We sometimes titrate up the dose with the goal of keeping the estradiol less than 500 picograms per milliliter. So I always start off 5 milligrams of letrozole, and I sometimes will increase it to 7.5 milligrams or 10 milligrams during the stimulation phase. We know most of the data in general in oncofertility, there's not great data. It's a relatively new field. Most of the data we have is derived from breast cancer patients. And that's no different when we're talking about aromatase inhibitors and the use of aromatase inhibitors. Again, the UCSF group have done a lot of the work in oncofertility, and a good colleague of mine, Molly Quinn, published this great paper in Fertility and Sterility looking at outcomes in patients with breast cancer with and without letrozole. And what they found was that the peak estradiol was markedly lower in the patients with letrozole compared to those patients without letrozole. As you can see there, a mean estradiol of 709 picograms per milliliter in the group with letrozole compared to 2,500 in the group without letrozole. And again, most of this is theoretical risk, right? We're trying to decrease the estradiol, we're trying to decrease the exposure of the endometrium to supraphysiological amounts of estradiol, but there's not a ton of data to show that stimulating these patients with or without estradiol, with or without the IUD, that there's much of a difference at all. So most of the stuff that we're doing is based on the theoretical premise that we're trying to decrease the estradiol exposure, the endometrial exposure to estradiol. And again, this is the outcomes. Again, looking at the outcomes, we want to know if we're giving letrozole, does that affect the number of mature oocytes patients are getting? And as we can see, the number of oocytes retrieved was not statistically significant. They found that there was a higher dose of, there was a higher number of M2s retrieved in the letrozole. That's probably just an outlier, but at least it does not seem to impact stimulation in a detrimental fashion. And we see that again here at Boston IVF. We do this all the time. Any of our patients, breast cancer patients or endometrial cancer patients that we're stimulating, all go on an aromatase inhibitor. This was a very interesting paper actually published in Human Reproduction a couple of years ago, done by a Japanese group, and they looked at xenografting endometrial cells into nude mice following mice that had gotten letrozole and mice that had not gotten letrozole. And again, they noticed that the tumor growth in the mice that had gotten letrozole was far less than the group that did not get letrozole. So although we don't have good human data, there's at least some preliminary animal models to suggest that giving letrozole during stimulation in a patient with endometrial cancer is protective. So in summary, again, the most important takeaway from this presentation is that it is so important to take a multidisciplinary approach to these patients with individualized care, to involve all of the subspecialists, or as many of the subspecialists that I mentioned in my slide, to allow the patients to make an informed decision, because as was mentioned by the previous speaker, not everybody has the same goals. Not everybody wants to have children, not everybody wants to carry children, but it's very important that those patients are aware of their options so that we can counsel them, we can treat them appropriately. One of the things you can do, and again, brings me back to that individualized care point, you can consider delaying stimulation until negative endometrial biopsy. You don't have to, you can. We generally recommend stimulating with an IUD in place. Again, it's theoretical, but it does not cause harm, and it may help. We typically use the antagonist protocol with an agonist trigger. Again, we want to shorten the exposure time, the exposure dosage of the endometrium to supraphysiological estradiol. And again, giving that agonist trigger helps to speed up luteolysis and again, decrease the duration of exposure of the endometrium. And then we routinely add an aromatase inhibitor, 5 to 10 milligrams during stimulation.